Welcome to When Prescriptions Are the Problem. Community event sponsored by the Freedom from Addiction Network. Our mission is to affect community change to reduce substance misuse and abuse, and our vision is health, wellness, and freedom from addiction. We are governed by the Cape Cod Justice for Youth Collaborative, a 501c3 nonprofit that acts as FAN's fiscal agent and provides administrative support. FAN's steering committee is comprised of community leaders elected by network participants. What do we do? So was community around a common vision of substance misuse and abuse prevention. Empower youth to make healthy lifestyle choices, identify and address substance abuse issues on Cape Cod that impact youth and families. Use evidence-based strategies to effectively reduce substance abuse and misuse. We are a community effort committed to building a healthy and safe environment for our youth and families, and a network of health professionals, educators, public safety officials, faith-based organizations, parents, and youth, working collaboratively in a grassroots effort to bring about population-level change. FAN has core principles, which include providing an open forum such as today, welcoming and respecting all voices, increasing awareness, reducing shame, and advocating for compassionate, effective public policy. We do have a community recognition award come up now on the agenda, but we also are on Cape Cod on Easter weekend, and some of those community awards are people that are coming and are not here yet. So I think if it's okay with you, we're going to switch that from the agenda perhaps a little bit later. And is that okay with you? Yeah, wonderful. So just a couple of facts. Most abused prescription drugs come from family and friends. Unused or expired prescription medication are a public safety issue, leading to accidental poisoning, overdose, and sometimes clear abuse for youth. The non-medical use of prescription drugs ranks second only to marijuana as the most common form of drug abuse in America. Unused prescription drugs are often thrown away, often to be retrieved and abused or illegally distributed. Unused drugs that are flushed can contaminate the water supply. Proper disposal of unused drugs saves lives and protects the environment. The majority of teenagers misusing prescription drugs get them from family and friends, and often home medicine cabinets. Many people keep medications beyond their expiration date and after they are discontinued from their doctor. There is no disputing the fact that opiate use has reached near epidemic levels throughout the country. Cape Cod is no different. Admission statistics at our local acute treatment center, Gosnold, FAN's partner from its inception, I want to thank Holly Carroll, who's from Gosnold here today, and Mary LeClaire for both being on our team, offer evidence of the impact of this drug on young people. 30% of the patients are under 24 years old, with 60% of patients reporting primary dependence on opiate drugs, most of them from prescription pain. Through focus groups, a pilot study, and surveys throughout the county, FAN offered an awareness, the Freedom from Addiction Network, offered an awareness of the need for direct intervention in the middle schools and high schools in the community, as well as assisted several communities to form coalitions in prevention, including Falmouth, Mashpee, Barnstable, Sandwich, Nauset, and Harwich. Many of these towns have begun the collection of data through the Youth Risk Behavior Survey and pride surveys that will help inform decisions regarding population changes based on prevention science that will address substance and low misuse on use. But everyone sitting here can be involved, as it takes a village. And as you see, we'll begin our agenda with a public service announcement that was put together with a community leader. This is Nicholas Polidor, and we'll start from there.
Hey, hi, I'm Nick Polidor. I go to Four Seas, and this is just a clip that Kate gave me from a Gosnell meeting, and it really stood out to me. So I just kind of put it together for this little clip that you're about to see. I also made 2 documentaries that you'll be seeing later today. I go here to the college, and I make films.
Hi, my name is Joanne Peterson, and I'm from Mount Cope, and I just want to say that yesterday I was in New Hampshire, and I got a text that we lost another one from Mount Cope. Just last Monday, I was helping a mom, get her son into treatment. She'd already lost another son over the summer. And I'm happy everybody's here, but, I just can't help but feel like I've been saying this for 10 years. I'm getting tired. We're all getting tired. And, the heroin that's out there right now is pretty potent. So if you don't have Narcan and you have somebody that you love or a friend that uses, get it.
So we'll move on to our agenda. How this day came about is a group of community leaders decided that it was time to do a forum around the prescription issue on the Cape. And so we set it out there, and we decided on when prescriptions are the problem, which would explore the unintended consequences of new medical drugs and drug policies. And so in the community, we put out the following description: medical marijuana and the new opiates. What do they mean for healthcare providers and patients? What do they mean for educators and law enforcement? What do they mean for prevention, treatment, and recovery efforts? And what do they mean for all of us? We'll hear now from Will Bouzier. Will is the Executive Director of the Interagency Council on Substance Abuse and Prevention from Governor Patrick's, to talk about Governor Patrick's declaration of the public health emergency. He graduated from the University of Buffalo and New England School of Law and was admitted to the Massachusetts Bar in 1978. Thereafter, he served as an Assistant Attorney General and Division Chief in the Criminal Bureau of the Massachusetts Attorney General's Office. He served as Assistant General Counsel to the Boston Rent Equity Board, and from 1995 to 2008, he served as Constituent Services Director, Chief of Staff, and General Counsel to Senators Warren and Stephen Coleman. He was appointed by Governor Patrick as Executive Director of the Governor's Interagency Council on Substance Abuse and Prevention in September 2008. He serves on the board of managers of the Oak Square YMCA and also chairs the board of the Vocational Advancement Center, providing jobs and job opportunities for people with disabilities.
Thanks, Kate, and thank you all for coming out this afternoon. A couple of statistics that I thought about while Kate was talking. In 2013, there were enough opiate drugs prescribed to provide everyone in the United States over the age of 18 with a 30-day supply. That's everyone over the age of 18. And that's one staggering statistic. The other staggering statistic that I recall is that for young people who are diagnosed with an alcohol use disorder, they're 18 times more likely to participate in the non-medical use of prescription drugs. 18 times more likely. So, why am I here this afternoon? On March 26th, the Governor Patrick met with 9 families for over 2 hours, and they told him about their struggles with folks who were addicted to opiates, heroin, and painkillers. And on March 27th, the Governor declared a public health state of emergency. Now, a public health state of emergency has a particular legal significance. It essentially means that the Commissioner of Public Health has broad authority to make sweeping changes to address that problem. And so there were some emergency steps that were taken on that day. One of them was that there was a regulation put in place that now allows first responders to administer Narcan. And so the Bureau of Substance Abuse Services will be in the process of ramping up training for police and fire officials, police and fire first responders, so they can carry Narcan and administer it when they see it's necessary. There was also a regulation passed by the Public Health Council on that day, the date that the public health emergency was declared, that allows pharmacies to prescribe and sell Narcan. And we just found out yesterday that Walgreens will be stocking Narcan, and so anyone can go into a Walgreens without a prescription, because there'll be a blanket prescription for everyone, and ask the pharmacist for Narcan. And of course, if it's not reimbursed, they'll have to pay for it. I know that the Department of Public Health estimates that a 2-dose Narcan kit is about $40. I don't know how much it's going to retail for in Walgreens, but in that neighborhood. The governor also accelerated the enrollment of physicians in the prescription monitoring program. They were required to enroll when their Massachusetts Controlled Substance Registration came up for renewal, and that would have meant 1/3 every year, 1/3 last year, 1/3 year, 1/3 next year. Now they all have to be enrolled by September 1st of this year. And the other thing that the governor did, which wasn't as successful as we hoped it would be, was that he banned the prescription of a hydrocodone-only extended release formula drug that was recently approved by the FDA over the objection of their scientific community, their scientific advisory board, which voted 11-2 not to authorize this drug. But the FDA went ahead and authorized the drug anyway, and it's a very powerful opiate that has some dire warnings on its label, including that you have to swallow the drug very quickly and swallow it with water, because if you don't, you're liable to absorb too much of the drug too quickly and you go into respiratory arrest. It's also, it says on the label that the drug cannot be ingested by anyone under a particular body weight, because they could go into respiratory arrest, which means that unattended children getting to this drug could be fatal. So the governor decided he should ban it. It was banned. The federal court on Wednesday decided that the governor can't ban it, that because the FDA approved it, that's the last word. So we're working now on Plan B, which will hopefully severely restrict the availability of this particular drug, which has the trade name Zohydro. So other longer-term solutions that the governor looked at, He said that he would allocate $20 million for the Bureau of Substance Abuse Services and others to deal with this issue. And on Wednesday, he filed a supplemental budget in the legislature, which includes that $20 million. And he also asked the Department of Public Health to work collaboratively with Mass Health and the Department of Insurance to define insurance coverage for addiction services, because the governor heard from all 9 of those families on the 26th of March that their problems with their family members being addicted, much of the problems had to do with the fact that they couldn't get insurance coverage, that they were literally bankrupted because of the need to deal with their family members' disease. And he created an opiate advisory task force. And the opiate advisory task force, the bare bones task force includes the Interagency Council's executive committee. And the folks who were on that executive committee are the secretaries and commissioners of the Executive Office of Public Safety, the Executive Office of Health and Human Services, the Department of Public Health, the Department of Mental Health, the Department of Children and Families, the Department of Corrections, the Department of Youth Services, the Bureau of Substance Abuse Services, and Mass Health. And the task force was charged with developing recommendations on how to spend that $20 million. And the governor asked that we look at how to better coordinate services, how to identify current data on the scope and gaps in the data, to ensure a full range of services regardless of insurance, how to divert nonviolent criminal defendants into treatment, and how to assist returning citizens from correctional facilities to maintain opioid abstinence. And this is the tough part. He gave us 60 days to do it. So we have a report due to the governor by the end of May. And I was thinking, as I was sitting in traffic waiting to get over the bridge, how much work I was missing, but that's my problem. So not only does it include those folks from the Executive Council, but it also includes people on the front lines, consumers, family members, public safety officials, the judiciary, healthcare and behavioral health provider agencies, local officials, local businesses, and insurers. And what we are trying to do is adopt a problem-solving approach. And you might want to take notes on some of this, because I'm going to ask you to do some homework. To identify the root causes of and drivers of the problem, to develop focused responses that address the root causes of the problem and the drivers of the problem, to consider short-term, medium-term, and long-term solutions, to consider realistic action steps that address prevention, intervention, treatment, and recovery support. And then, how do we measure success? And so we've been going through a process. We've had 3 focus groups so far. We will probably have a dozen more focus groups before we start to generate the report. And so what I would like you folks to do is, you don't have to do it right now, but when you get home tonight, think about how you would address the opiate problem with regard to prevention, with regard to intervention, with regard to treatment, and with regard to recovery support, and how you measure success. And for any of you who want to submit written comments to me, if you would be so kind as to think about that and do it before next Friday, the 25th, then I will make sure that those comments get included in the report that goes to the task force. So my email address is william.luzier, Luzier, @state.ma.us. And please let me know when you send the comments along that you were at this event and that you're responding to my request. And for those, I'm going to take everybody's name when you leave, and if you don't give me a comment, you're going to get an F. But anyway, so we have a lot of work ahead of us. You know, it's a terrible problem. I will tell you that on the 1st of April, I left my office. I walked down Washington Street to School Street. I walked up School Street, and I was, on the way to turn the corner by the Parker House. And just down from Old City Hall, I saw a woman go down in front of me in an apparent overdose. Her boyfriend had her by the shoulders and said, "Wake up, June, wake up." There was somebody there to do rescue breathing. We called 911 right away. They came in about 5 minutes. They put her back in the back of the truck. I don't know what happened after that. I've been trying to find out from folks in the city of Boston whether they were able to revive her or not. And the same thing happened to a friend of mine who also works in the Bureau of Substitute Services a couple of days before, a couple of days afterwards, in a different part of the city. So, it's happening all over. It's happening in the middle of the street, and it's an awful problem. But we're going to try and find some appropriate solutions to it. And I appreciate the opportunity to let you know about what the governor's doing. And any questions? Should I ask questions now?
Yeah.
Okay, questions at the end. Thank you very much.
Thank you very much, Will. And we'll continue to move forward. Nick will again present a local response and what Cape Cod thinks about prescription drug law.
Okay, so I made another movie about the opiate problem on Cape Cod, and this one I took it very seriously. I took footage that Kate gave me. I recorded my own footage, and I got several interviews with several personal friends. I interviewed a retired police captain from Wareham. I was honored to interview Randy Hunt, and I interviewed some people locally about how serious this problem actually is, how the public actually views it, and how seriously it needs to be treated. I tried to get different perspectives. I tried to get some youth. I tried to get some elders. I even got a dude that I work with. So.
We are all realizing what a huge problem this has become.
Again, we're starting to see this incredible mushrooming of addiction and drug-related damage, really, all through our society.
Those of us who are working in this area of healthcare understand that what we're dealing with is not a problem that rises to the level of emergency, crisis, and acuity in a moment. We're dealing with a condition that exists for the duration of a person's life.
First of all, there's more opiates being used than there have been in years. It's readily accessible, it's cheap. And young people, along with old people, are gravitating towards it.
This is not a Republican or a Democrat or a conservative or a liberal issue. This is a priority in public health. We all need to be partners in this.
We need to understand what is effective for addiction treatment. We need to make sure that we have enough availability of that treatment so that we get rid of the cue.
How serious do you think the opiate problem on the Cape is?
Extremely serious. Very, very serious.
How seriously do you think it's taken?
Recently, I believe it's been taken very, very seriously. Prior to that, I think they weren't coordinated enough, and I think they realized with the amount of ODs and the amount of deaths and the amount of crime that's going on, that they, not only on the Cape, but statewide and nationwide, that they have a very, very serious problem on their hands.
Well, the opiate epidemic on the Cape and in southeastern Mass and really the entire Commonwealth is a huge problem for us. It has been since 1995, even before that, but in 1995 out comes an opiate prescription medicine called OxyContin, and that medication turned out to be the most addictive medication that has ever been manufactured.
Well, first of all, you have to start at the school level. And if you don't have the parents helping the kids through the traumatic issues, it's going to just expand.
High school kids in Sandwich, and I think this is probably replicated around other schools, I'm sure. Kids rank smoking cigarettes above in danger to taking prescription drugs, bath salts. These other things are down the list because I think that we have been effective at letting people know that smoking cigarettes is bad. It's a difficult thing, education and prevention, because it's hard to prove that somebody did not do something because of an education program. You know that would work with cigarettes, but it's something that has to be sustained over a long period of time.
What does your high school do to educate you on opiates?
Not much at all. I mean, they're like at school sports meetings, they're like, oh yeah, use of drugs will like suspend you from the team for 30 days. But they're not like, hey kids, don't smoke. They just don't say anything.
We know that the big problem, and you know so well, the big problem is missing the window. We do not want to miss the window when people have finally gotten to that point where they can make that attempt to go to treatment. We have to be there. We have to be there in a big way. I know that from being a doctor. And so a large-scale system of regional coordination points that work with all of our treatment centers so that there's a number to call and everybody knows it, so that people can get right into treatment in that small window is important.
This is one of the big problems that we've had for a while, is there's a stigma that's associated with addiction. And people don't want other people to know that somebody in their family has an addiction, whether it's from alcoholism or a drug abuse issue. And so we often sweep it under the rug. And here in our own wonderful, quaint village, seaside village of Sandwich, we have a heroin problem. We have a prescription opiate drug problem. Yet we're still shy about talking about it, about admitting how big the problem is. And until we do, we're going to have a hard time trying to find solutions, because people have to, like in a 12-step program, step number 1 is to say, hey, I got a problem. Well, this community needs to say, hey, we've got a problem. And when we get enough attention to that, then I think we'll be able to make steps forward.
What do you think the law should do with people who have problems with opiates? Should they stick them in jail?
I don't think jail does anything whatsoever. From my experience with people that I know that have been in jail, it's a revolving door. They end up going in and out, in and out, in and out. There's never any follow-up. I think you need long-term in-house residential treatment programs that are state-paid or federally paid, because short-term programs don't work, and even long-term programs have a fairly
low rate of success, but I think you need anywhere between 8 months to probably a year and a half of programs and vocational training for people to get them back on their feet again.
I have a bill that's called the Assist Act, and what it does is focus on those people that are in the court system who are addicted to alcohol and or drugs and who are nonviolent offenders. And the reason that I chose that group of people is because they create probably 80 to 90% of the property crimes that we see around the state. In fact, just about every breaking and entering, thefts of cars, thefts of things in cars, houses, etc. All of that happens because people are trying to get money to buy drugs to be able to stay high.
What are the steps the Cape could eventually take to eventually minimize this epidemic?
What we have to work on is getting people well. Drug addiction and alcoholism are a lifelong affliction. We have to think about addictions as being a mental health issue as opposed to being something that we want to just ignore and stigmatize and sweep under the rug. So what we need to be able to do is to get at the people at various different points.
So I'd like to thank everyone that I was able to interview for that, and I just hope that would really speak as to what's going on in our community. What I found really special was I got to interview my brother, who was kind of forced to agree to my interview. So he goes to Sandwich High School, public high school on the Cape, and clearly he's 16, he's a sophomore. I graduated from there. I was never really told how big of a deal it was, except until we had Chris Herron come in. And I've heard, going through my footage I had, that he'd done talks before, and that really spoke to me. And to hear from what Jeffrey had to say about what they're doing, because he wasn't there for the Chris Herron talk, because it hadn't happened in a long time. So I just felt that was very important to say, especially from Barry's perspective, from retired Captain Carlito's perspective, from Randy's perspective, and from Jeff's perspective. So thank you guys.
So before you leave, we did switch the agenda, as you see. Nick's going to have to leave us early. So if there's any questions after the marijuana piece directly for Nick, if you're open to
I love answering questions.
That's part of why we did a little bit of switch. And how about a round of applause?
Not often seeing me 6 days a week at Abishon.
So on our agenda, as you can see, it's switched. The topic is opioids and epidemic, and we're so fortunate to have an amazing speaker. I'm going to tell you a little bit about her. Dr. Bertha K. Madras. The biography would be pages long, but I'll briefly touch on some of her accomplishments. Her current position is as professor of psychobiology at the Department of Psychiatry at Harvard Medical School. A neuroscientist, she is located at McLean Hospital in Belmont, Massachusetts. Previously, she created and chaired the Division of Neurochemistry at the Harvard Medical School, NEERC. As a scientist, her research focuses on comparing effects of drugs on the adolescent and adult brain. Her research has focused on addiction biology and other neuropsychiatric diseases, described in over 140 manuscripts, 20 book chapters, and over 200 abstracts. As an author and editor, she is principal editor of books The Cell Biology of Addiction, The Effect of Drug Abuse on the Human Nervous System, and co-editor on Imaging of the Human Brain in Health and Disease. And as an inventor, she is the recipient of 19. As an educator, she developed and taught the course on addiction, biology, and treatment for fourth-year Harvard medical students, created an international course on cell biology of addiction, and Cold Spring Harbor Laboratory. She has delivered numerous continuing medical education lectures, grand rounds. She's organized 3 White House conferences on medical education on substance abuse. As Deputy Director, Demand Reduction, White House Office of National Drug Control Policy, her presidential appointment was confirmed unanimously by the U.S. Senate. And in service to the public, as she has today, we're very blessed to have her. She directed creation of a museum exhibit, a CD, Changing Your Mind, Drugs in the Brain, for the Boston Museum of Science, and assisted the National Institute in creating storyboard for a museum exhibit in Times Square, New York. She's developed over 450 invited presentations to educate the public on drug awareness and biology. And she's the recipient of many, many, many awards, and I'll just touch on some. A Public Service Award, American Academy of Addiction Psychiatry Founders Award, Marion Fishman Award for Outstanding Women Scientists in Substance Abuse, a brain imaging agent strategy she developed was cited by the Federal World Report 2006 as one of the 25 technology transfer innovations that changed the world. Her experience in translational neurobiology, government, and public service afford her a unique perspective on the science of public policy. Dr. Madden.
Thank you very much for that lengthy introduction. It's time for me to hide under a chair. I have served in many capacities and many hats, and each one of them has been very informative in terms of public policy, and I'd like to touch on some of them. Heroin addiction, fortunately, has not touched my family, but it has touched me personally through stories, through reports, through statistics, at many, many levels. The other day, there was a young man who was in a community college who was in my office part-time, helping me archive a lot of my research for the Women in Archives in Medicine at Harvard. And he came in one day very sadly, and I said, "What's wrong, Josh?" And he said, "My very good friend from high school, who was also in community college, overdosed and died this weekend." A few years ago, I met a father who was so desperate to get his son off opioid addiction that he quit his very good job in Texas to drive up north, anywhere north, away from the environment and the culture that his son was involved in. And his son had a car, and they both agreed to meet at a certain gas station in northern Texas so that they would continue their journey. The son never showed up because on the way he stopped to say goodbye to his friends. They handed him a few prescription opioids, and he died of an overdose right there and then. There are too many stories. It's unacceptable. Our society has to put an end to this, and there are many, many approaches that we can, collectively, professionally, in terms of family and culture, to reverse the trends and begin to grapple with and also conquer this problem. As a typical academic, you'll have to forgive me because I always start with a summary of what I'm going to talk about. What is prescription drug abuse? How big is the problem on a national scale? What drives it? What are the adverse consequences? And what are some of the solutions? So let's begin with what is it? It's the use of medications prescribed for medical conditions by a patient who self-escalates the dose, who just keeps taking more and more. He takes it more often and differently from the prescription, uses it for psychoactive purposes to get high or for other purposes, and by a non-patient because the prescription is diverted to others with unregulated doses and frequency for the same reasons, to counter anxiety and sleep and improve learning and what have you, but primarily to get high. The problem is huge. In terms of misuse of opioids, it's number 2. This got displaced in the transfer to this new to PowerPoint 10. But it's number 2 next to marijuana, compared with marijuana in terms of frequency of use. What drives it? Access, the individual, and the drug effects of all. What are some of the issues regarding the driving? First of all, the emergency department visits involving non-medical use of narcotics. We can see that hydromorphone, which is not very widely used, fentanyl, morphine, methadone, hydrocodone, which is Vicodin, oxycodone derivatives, which are OxyContin. Their number of emergency department visits have doubled in just 4 years. Why has this been so? The previous speaker alluded to the fact that every person over 18 can get a 30-day dose with regard to the number of prescriptions in our country. Let me put it quantitatively. There are 9 billion pills, opioids, 9 billion prescribed every year in our country. And the reason that they're prescribed and the reason this has become such an escalating problem is because there were a few reports in the medical journals, very reputable ones in the late 1990s, saying that these drugs could be used for chronic pain. Up until that time, physicians were terrified of opioids, and they would administer them for acute pain, for post-surgical pain, for tooth extractions, for cancer pain, terminal, dreadful pain that people have, especially with regard to bone pain. And then these reports came out saying it's okay to prescribe these drugs for chronic pain, that other drugs don't really suffice. They don't really work. And so what we saw is this tremendous escalation of sales of opioids, starting literally with the publication of these papers around 1999, 2000, and this keeps going up and up and up. And we've also seen a concomitant escalation in the number of deaths in the blue line. And so we have to begin to look at the whole issue of are these valid prescribing practices for pain? And we can get into that in a few moments. What drives prescription opioid use? The opioids are available. When I served in the White House, we were concerned that it was internet sales, because you can click on the internet and look for OxyContin or Vicodin, or using their generic names of hydrocodone and oxycodone, and sources from China, from India would just sell you the pills. And it turned out, when we interrogated very carefully, those pills through the internet were a tiny source of access. The major source of access is free from friends and relatives. Now, what does that say to us as people, as citizens? It means that we're not guarding our prescriptions. That's what it says. It says that right now we have a solution, a partial solution to the problem, by taking care of what's in our medicine cabinet and discarding what we don't need. Of course, there are many other issues involved, and we will hear more of them. But for example, a dentist who prescribes 90 Percocets for a toothache or an extraction is irresponsible, because that pain disappears within 2 days. You probably need 10 of those pills, not 90. And what happens to the other 80? Are they being passed around? Are they being sold on the streets? Are they being stolen from a medicine cabinet? So the biggest source of the problems are emergency departments, dentists, and a few other types of physicians that deal with heavy opioid doses. These are the sources of these pills. So most people get them free from friends and relatives. Some buy them from friends and relatives, only 15%. Some doctors shop and get them from their doctors and then abuse them. Others, doctors shop and get them from more than one doctor. The drug dealer is a small percentage, and other includes stealing, clinics, pharmacies, hospitals, internet, fake prescriptions. But basically, this problem can easily be addressed by vigilance in the home. And by patients looking at their dentist and doctor and saying, don't give me a prescription for 90 pills. I don't want it. I don't need it. I don't use it. So who are the users? The persons who abuse only prescription opioids, the heroin addicts who can't get access to heroin, people who use prescription opioids just to get another type of high, they're not steady users, and pain patients who develop an opioid use disorder in the course of legitimate medical treatment. Now, how many of these people develop an addiction? We simply don't know. We've had ranges from 5% to 30% or even higher, and the final numbers are not in. It's very difficult to guesstimate this. Who is at risk? People more likely to be male, young, have a prescription history of more opioids and many days of supply, have prescriptions filled at more pharmacies, have greater rates of psychiatric problems, they use more medical and psychiatric services, and they're prescribed a number of medications. There was an overdose case in West Virginia a few years ago, not a couple, and the person had 100 prescriptions for opioids when the EMT showed up because he died of an overdose. And he had gone, because West Virginia is flanked by a number of states, he'd gone from state to state, and nobody checked with the prescription drug monitoring program to try to identify whether or not this was an abuser. Who is at risk? Anyone who uses opioids for long-term management of pain, anyone who uses heroin, who receives different opioids on a rotating basis, anyone who's discharged from the emergency room for opioid overdose or poisoning, anyone who has a legitimate history of needing a painkiller but also has a substance use disorder, anyone who's finished a mandatory opioid detoxification or released from prison and is a past abuser. What we are learning, and there's no question because of the data, that people who abuse opioids are far, far more overrepresented amongst people who abuse other drugs. Among the 12 to 17-year-olds, if they don't use alcohol, their use of opioids is 1/10 that of people who have young kids who abuse alcohol. Binge, not heavy, use but not binge, it goes down and down, but alcohol is clearly a factor. And the opioids, we have a shopping list of them that are prescription opioids that are approved, that are Schedule 2 or 3, they're methadone and codone or hydrocodones and hydromorphone, pyridine, morphine, fentanyl, oxycodone, pentazocine, propoxyphene, tramadol, buprenorphine, you name it. There are a lot out there. The route of administration is primarily oral. That's actually helpful to some extent, because the faster an opiate gets into the brain, the more addictive it is. So that IV is the most rapid way to enter the brain, and inhalation is also extremely rapid. So there is a bit of good fortune that most people use. It's hard to call it good fortune. Here's the problem. Because these opioids are so effective orally and are chemically designed to be effective orally, you don't have the aversion to using needles as some people do. And that's one of the reasons people don't get into heroin addiction, because they have an aversion to using needles. And here they have an option which is not only medically clean, pharmaceutically clean, but is active by mouth. So it is a problem, because the protection that individuals have, because they're revolted by injecting themselves, that protection is gone with opioids that are active by mouth. What are the risk factors in terms of patients? Early refills, age at first prescription drug need, the number of prescriptions, the number of pharmacies, dose escalation, but the real big one is non-opioid substance use disorder. People who have a history of abusing alcohol, abusing marijuana, those are the folks that are the most at risk for abusing opioids. The age range we've discussed, we won't get into it. And this is primarily a Caucasian problem. There are real interesting, intriguing racial differences in terms of what drugs are attracted to, what subpopulations. And opioid addiction is prescription opioids is far more prevalent amongst Caucasians than it is amongst other subpopulations. That is not the case for certain drugs such as cocaine. What are some of the consequences? Some of the consequences are really a problem. If a person is cut off from their supply of prescription opioids, either the family has thrown out the stash in the medicine cabinet, or they have locked the medicine cabinet, or they start to count the number of pills that they have in the medicine cabinet. Some people, and there's a growing problem, are now converting to heroin use. What is the problem with that? It's a dreadful problem. It's equally daunting and equally grave, because heroin use almost invariably, but not exclusively, involves intravenous injection, about 85% or so. And heroin use means dirty street drugs. Heroin can be laced with fentanyl, or it can be fentanyl, which no matter how much Narcan you have, if you have enough fentanyl, you will die with the needle still in your vein before you even finish injecting, because fentanyl is so powerful. So there are so many problems with prescription opioid use and ramifications, including the escalating use of heroin, which some people think is being driven in part by prior exposure, to opioids. The other consequence is in terms of a substance use disorder. After marijuana, it's prescription opioids. Half the people that are reported in the NISDA survey that came out this September, twice as many are addicted to marijuana but number 2 is prescription opioids, and cocaine is number 3. This was very different a decade ago or 2 decades ago. Cocaine was much higher up on the pecking order of this morbid and sordid chart. We've already also seen a 270% increase in treatment for opioid addiction in the past decade, to say nothing of this dreadful death rate. This only goes up to 2004, but Len Palauzi of the CDC has data that's much more recent. I just haven't updated the chart. We're also seeing maternal opioid use before giving birth. We're seeing that the number of births of children in withdrawal from opioids is escalating, and hospital charges are going way up. Another enormous problem. Newborns with neonatal abstinence syndrome are much more likely to have low birth weight, to have complications with breathing, longer hospitalizations, medically complex problems, and very high costs. What are the consequences to medical practice? There are consequences also to how physicians deal with their patients. Practitioners, many have no training, little or no training in pain management in medical school. They're now becoming terrified of prescribing opioids and terrified of having to manage the consequences. So what is the result? The result is there may be underuse of opioids when it's appropriate. The result is potential failure to monitor, detect, and manage the consequences. What are the solutions? The first solution is education. But the first line of attack, the first line of approach, we talk about teaching this at school, we talk about communities getting together. We know from NISTA data and from other reports that the number one determinant of whether or not young people use drugs is parents. If a parent says, I don't want you to use alcohol, this is not a rite of passage, it endangers you, a child will use at 1/5 the rate. If a parent says, I don't want you to use marijuana, and explains why, it should not be a police state in a home. It should be, here are the reasons that terrify me or concern me about use. You may get away with it, but you may not. If parents say and they take a strong stand, 5% of their children will use. If they don't discuss it, or if they approve of it, 35% of those children use marijuana. And we don't have corresponding data with opioids, but I am convinced that if it's true for 2 drugs, it will extrapolate to opioids as well. We need to educate parents, and they need to educate their children, and we need to educate youth and college-age students about the dangers of using prescription drugs, because they are lethal. Opioids are lethal. In an overdose situation, they prevent your brain from controlling your breathing, and a person dies of respiratory failure. Stop breathing. We need to educate the prescribers on safe use. We need to monitor. The prescription drug monitoring programs are growing. They can be effective, but they are spotty. They are not being used as effectively as they can be. They are not integrated properly on a national scale. We need to dispose of medications and control them in our own homes. The prescription drug monitoring program is an official, it's a federal, state level. These are the kind of issues that you ought to expect of your representatives at the state level, at the level of the federal government. But we, as citizens, can control our own prescription drugs. We can monitor them and we can toss them when we no longer need them. We should count our own pills. I have spent countless hours talking to pharmaceutical companies saying, please just print on each pill a number on the package, on a blister package, so you see that you've used 1, 2, 3. Prescribe them in blister packages numbered. Then a person can say, wow, I know I've only taken 4. There's 10 missing. Where did they go? That's not being done. We need enforcement. We need law enforcement. Because there are bad actors in this field. There are bad actors with regard to physicians. There are bad actors with regard to pharmacies. There are bad actors with regard to people who sell pills. And what you can do is dispose according to guidelines. Talk to your children. Use the community take-back programs. And above all, if you know you have a family member who has a substance use problem, seek treatment for them and individual recovery. What others can do, promote tamper-proof opioid formulation. Aggressive investigation and prosecution. Urge the pharmacy to do a fraud and abuse screen automatically, including checks of the PDMP data. Urge the pharmacies to validate the registration of prescriber and pharmacist. Urge the pharmacy to get access to vital registries, and so on and so forth. Physicians have a tremendous responsibility in this particular issue because they're the ones who prescribe, and the dentists as well. And they have to adopt universal precautions, screen patients, stratify them in terms of risk, make sure that individualized treatment is periodically assessed. Urine drug testing. Anyone who's prescribed an opioid should have periodic urine drug testing. Pill counts to make sure that they are adhering to the schedule, and documentation. I'm not going to go into the universal precautions of pain medicine. The other issue is that every physician in this state, every physician in this country should engage in this ESPERT, which is a public health solution, to screen every patient for substance use issues, to administer brief intervention or treatment and refer them to appropriate treatment. 95% of the population in our country have a substance use problem, problematic or risky or abuse or addiction. 95% go unrecognized and are unaware, do not seek treatment. The front line of attack for this should be through the physician. 21 million people need but do not receive treatment for substance use disorders, and at least twice that number are engaged in risky, problematic use. So the core components are to screen people, to intervene, to provide treatment, or to refer. We've heard from our previous speaker on Narcan. I was on the FDA panel, on the advisory panel, on the debate, the discussion, the heated discussion on what to do about Narcan. And I have made a number of statements on Narcan, which some of which have been accurate, others of which have been completely inaccurate. My foremost philosophical and bottom line is that every human being is precious. Every life is precious. And number one is we must save them at all costs. And if we find over the years that Narcan will save them, regardless of sources, that will be an important step forward, because if they live to see another day, they can live to see a day of treatment. The problem with anonymous pharmacy purchases of Narcan is that it is like a patient who has a heart attack in a shopping mall. They have a heart attack, somebody breaks the glass, takes up the paddles, resuscitates them, and then tells them to go home, and that's the end of it. The big problem I see is that people who are not entered into a medical care unit, into a medical service provider with addiction, is a continued risk, like a heart attack patient, a continued risk for dying. And that's the thing that we must prevent at all costs. So I still firmly believe that people who are addicted to opioids need to be urged into treatment. And that's so critical, because this is a chronic, lifelong disease. Some people grow out of it. The people who grow out are usually the ones without psychiatric problems, without personality problems, without social problems, without employment problems. Some people do grow out, but a lot of people don't. And if we do not embrace them, that is a problem, and allow them to remain anonymous. We don't know when the next hit will contain fentanyl or a long-acting drug like methadone or some other drug where Narcan will not reverse the overdose. The other thing we should consider is that we've had many debates on whether or not marijuana is a gateway drug. We hear this over and over. It's not, it is, it's not, it is. But there are enough studies that show that the number of people who engage in opioid use and addiction, who have not been smokers, drinkers, and marijuana users, is low. And with the passage of 2 bills in the state of Massachusetts that decriminalizes and that promotes marijuana as medicine, we are going to see more and more people who enter the field, enter the realm, the domain of seeking psychoactive substances. So I'm very concerned that the marijuana movement is going to exacerbate it as well. So in summary, we've looked at what the abuse is, we've looked at the magnitude of the problem, what drives prescription drug abuse, the adverse consequences. And the solutions are within every single person in our society. Parents, educators, law enforcement, physicians, pharmacists, legislators, all of us. We all have to combine our strengths to combat this problem. Thank you.
We'll move on with the schedule, but I also do want to say that in the House, we do have, you mentioned that it takes a village, and we're so lucky in Cape Cod that we're ahead of so many communities. We do have our district attorney attorney here, and we've got our representative here, and we have Gosnell treatment here, and we have Senator's office here, and so we're so blessed compared to many. But we also have youth, and so we're going to move on to the next presentation. Are you ready, Nathan? We will have a Q&A, so if you have any questions, we also have AdCare Hospital here. So if you have any questions, and we have Marianne Frankulis from Moore here. We're very, very blessed in the audience. While he's putting that together, there are solutions. There is a Fed Up rally. This is another thing that Dr. Madras mentioned at the White House. And we have a local group that also needs to take back prescriptions. There's a prescription take-back program, and that happens on Cape Cod, and it's fueled by several different areas of Cape Cod. The Trauma Prevention Partnership, which I've been a member of since its beginning, does them, and all across the Cape, and that's April 26th from 10 to 2 p.m., and it'll be happening in many areas of the Cape. So Dr. Madras mentioned how important it is to get those out of the medicine cabinet, and this is a good way to do it.
If people go to dea.gov, there's a link there they can click and find out where the nearest drop-off site is on the 26th of April.
And we also have sites that are kiosks that are here full-time on the Cape, so
There are
please look it up.
150 of those throughout the state.
Thank you.
All right, so I've decided that work can wait a little bit. I've been there for over a year, so I told them this is a big deal. So I made another little movie about medicinal marijuana on the Cape. Once again, I interviewed some high schoolers, and I interviewed some older gentlemen, and you're not in that classification of older gentlemen, don't worry. Their perspectives kind of altered. I wanted to get different views, and this was taken a little more lightheartedly, less life-threatening than the opiate piece I did. And it's a little shorter, and once again, this is just kind of get an overview of the voice of some different sides of what the Cape thinks about the effect and the coming medicinal dispensaries when the time eventually comes.
So what kind of effect do you think the permission of medicinal marijuana will have on the Cape?
I think it'll be great because, including myself, much of the population on the Cape believes that there are many benefits to medical marijuana, and that it can help, not just be bad.
A positive effect, definitely a positive effect. I think there's a lot of people that traditional medicines haven't been working on, and I think medicinal marijuana is going to help a lot of people with a lot of different ailments.
I think it should be used for terminal illnesses, and I think it's cool whatever if you actually need it. It's good. I'm kind of worried about it getting out of hand and everyone getting it, but that's all.
I want somebody to tell me the difference between somebody getting high on marijuana and getting high on alcohol. All right? As far as I'm concerned, there's no difference. All right? Except alcohol is legal because politicians made it legal.
The law that was passed, we have to keep this in mind, was passed in 2012 at the ballot. The state legislature did not pass the medical marijuana bill. It was a ballot petition that was passed in November of 2012. And in it, it describes the types of conditions that people may have, like chronic back pain, Crohn's disease, some cancers, but the language itself ends that list with, and any other condition that is determined to be debilitating by a doctor.
I only know one person right now that has a permit or whatever it is to get medicinal marijuana, and it's somebody who has had Lyme's disease, which is an autoimmune disease, and it's been helping her greatly, more than any of the traditional medicines have been helping her.
I don't think anybody qualifies it. I think there are enough prescription drugs in the market, all right, to help people through whatever pain that they're experiencing, all right? I think an awful lot of people use medicinal marijuana strictly for party use.
The law says you can grow your own 2-month supply of marijuana because there are no dispensaries available. That law will continue to be in place for anybody who lives more than 35 miles from a dispensary when they finally do come up.
Do you think in the future the Cape will ever see legalization of marijuana?
I have no doubt that on the ballot in 2016, there will be a broad legalization of marijuana for recreational purposes. And I also have no doubt that that is going to pass.
Well, the way things are going, I'd be willing to bet that in the next 10 years, all states, that's all it boils down to is, okay, now government's getting involved so they can tax it. There are people out in the street that are still selling it, in which the state's not receiving any revenue because of it. So why not turn it around, legalize it, and look at the amount of taxation in the money that has been made by taxes for Colorado, Washington, and a few other states that have legalized it. And it's going to spread all over the country because they found out a new way of taxing, a new way of bringing money into government hands.
Stewart is president of the American Society of Addiction Medicine, chair-elect of the American Medical Association's Council on Science and Public Health, and a board member of Smart Approaches to Marijuana, which, by the way, we did host Patrick Kennedy at our last Freedom from Addiction event. He has worked in the field of addictive disease for 20 years and is board certified in general addiction and forensic psychiatry. He is an associate professor of psychiatry at the Mount Sinai School of Medicine in New York and serves as executive director of the Annenberg Physician Training Program in Addictive Disease. And with no further wait, Dr. Gibb.
Hi, everybody. So I'm going to go off script a little bit, given everything that's come before me, because frankly, I suspect we're doomed. And let me give you a little background as to why I think that. There's a couple of issues here, but my bias, I was 17 years the medical director of Nantucket Community and Family Services. We started that in about 1992. And the population in Nantucket was about 10,000, give or take, over the years that I was there. We had multiple deaths secondary to heroin or other narcotics each year until about 10 years ago when buprenorphine first became available. The reason that we had the deaths was that no one with opioid dependence was coming into the clinic. They didn't believe that we could really provide them much in the way of service. They weren't looking for medical care. Some of them went to counseling. But by and large, there wasn't very much available to them on the island. So we were losing folks every year. Well, 10 years ago, we started to provide buprenorphine through the clinic on the island, and we very quickly got to the 30-person limit that you're capped at under Data 2000. The cap then rose to 100. We very quickly rose to 100. Now, most of the patients were coming to us on the island, but the island only has 10,000 people, so obviously the 100 probably weren't all coming from the island. In fact, they were. A good percentage of them, about half, were coming from off the island. And that's fine. People are allowed to travel from one county to another to get treatment, unless you happen to be a resident of Nantucket and don't like the fact that narcotic addicts from off-island are coming to your island to get treatment. In which case, you'll go to the town and say, unless the clinic cuts off treatment to people from off-island for narcotic addiction, we won't support the giving of money to support the clinic anymore. Well, push came to shove, and about 3 years ago, the clinic basically said, we give up. We can no longer treat people with opioid dependence, with buprenorphine, because they gave me a choice. They said, you have a choice. You can, as medical director of the clinic, either turn away everybody from off-island and continue to treat just the people on island, or you can shut it down. And I said, fine, shut it down. And I took all of the patients, moved to my office in Rhode Island, and I see them all there. And the ones who are on the island now come off the island, drive an hour and a half to see me, and then go back and take the ferry back over the island. That's absurd. It's ridiculous. I make more money this way. It's fine by me. The patients can't stand it. And of course, Nantucket no longer has the influx of people coming over the island to get treatment anymore. Interestingly, I've lost, as you might expect, some of the patients from Nantucket because it's a schlep and a half to get to see me. So what's happened since we shut down the buprenorphine clinic on the island? Heroin deaths went up. Just what you would imagine would happen, because other than a very small amount of buprenorphine being prescribed by some of the docs on the island, the clinic's not available anymore. So now, why do I start off there? Why do I start off with the we're doomed issue? Because this happens everywhere. It's not just Nantucket. To give you an example of what happened in my own town, after I moved back, I opened up my office in Lincoln, Rhode Island. Nice medical office across from the high school, in a medical building. There were other doctors around me. And I saw my general psychiatric and addiction medicine practice. Except now I was seeing 100 patients who were being treated with buprenorphine for their opiate dependence. Well, the other doctors didn't like this element coming to the office building. So they pressured the landlord. And the landlord said, you can't see that many of these people. Really? They're not doing anything wrong. They're not breaking any laws. The police have never been called in. They don't make too much noise. Yes, they get here a little bit early in the morning, but that's because they're driving 2 hours from the Cape and want to make sure they get here in a timely manner. No, not good enough. So we had to shut that office down. And my wife and I, we have 200 patients between us. We've been about 1,400 patients total in our addiction practice. Had to move to an old mill building in Woonsocket. Again, cheap for us, but the building doesn't look like a medical office. It looks like an old mill building. But we have no neighbors, so the patients were able to come and see me. All right, so here's my question. If faced with these kind of difficulties, how many physicians do you think would be willing to go to this extent to continue to serve this population? Not very many. And so we're sitting here right now in the exact same position as the other doctors treating patients with buprenorphine for opioid dependence. I have a waiting list of 500 people between my wife and me. We're only allowed to see 100 people apiece and treat them with buprenorphine. We have 500 more people waiting to see us. We're private practice docs. We can stay open as long as the patients will keep coming into the office. I don't have any limitation, except with this disease. And that's another bizarre thing. With this disease, it's the only disease in the entire country of anything that any doctor treats where there's a limit set by a regulation that's federal that prevents us from treating the number of patients that exist with the illness. So if I want to treat all 500 people on my waiting list, nope, sorry, you can't. Why? Is there any reason other than a political one as to why? And moreover, why right now? You saw the statistics. The number of opioid-dependent people, for a variety of reasons, has been rising dramatically over the past 14 years. There's been no change in the cap for the past 10. So we're sitting here, limited in terms of the number of people we can treat. While the number of people with the illness grows and grows and grows and grows, there are no more doctors coming in to treat this specific illness. Right? We generate about 50 a year, but frankly, 70 a year are retiring from addiction medicine practice, so we're not even keeping up. We're not in a good place right now. Let me give you some other points, and I'll circle around back and hit the marijuana point, but I need to talk about opioids for a second because it all ties in. The first thing is, what's addictive disease? to have an understanding of what addiction is means that you have to understand that addictive disease doesn't have anything to do with drug use. Addictive disease is a disorder of the brain in which the brain perceives the world differently than it does in 90% of the population. It affects roughly 10%, 15 maybe. So I have to try to convince you, and you're going to be easy. It's the general public that's difficult, that 90% of the people aren't the problem. They're not the issue. Now, let me boil it down. Let's say we all go outside, bright sunny day outside. How many of you would immediately put on sunglasses? Right. Some of you did. The rest of you didn't. It was about 50-50. And that's what I get every time I ask that question. Why? It's the same sunlight, it's just as bright. The difference is that different brains are wired differently. We're set up to perceive stimuli differently, just as our heart beats at different speeds, our body temperatures, all are on a bell-shaped curve, heights, weights, IQs. That's the way humans are built. Some people are on one end of the spectrum, some people are on the other. So you go outside, it's a bright sunny day, you go, oh my God, it's bright, it's terrible, I'm gonna grab my drug. And your drug happens to be sunglasses. There's no downside to sunglasses, no risk, no tolerance, no withdrawal. It works perfectly. It turns the volume down. Now, a good portion of people can go outside on a bright sunny day, they say, this is perfectly comfortable. I don't notice anything wrong. Addicts all start out with the perception that the world is an uncomfortable place. They're stimulus augmenters. They need sunglasses. When they discover the sunglasses, by putting them on, they feel better. Not different, but better, subjectively improved. So that when you talk to an addict and say, tell me about the very first time you used a drug, the addict's response is, I felt normal. I felt the way I think everybody else feels all the time. I felt right. You talk to a non-addict about how they felt, and they say, I felt different, I felt funny, I felt worse, right? Because if you take a stimulus augmenter and you give that person alcohol, for instance, they generally say, I felt nauseated, I was uncomfortable. I usually don't drink very much. But a stimulus augmenter feels better. That doesn't make the person an addict. It simply makes them susceptible. So what makes them an addict? An addict is part two of the problem. You take a person who's susceptible by being uncomfortable in the first place, and you make it so that they do not have an adequate coping mechanism. And you do that through bad parenting. You're either irresponsible, inconsistent, overbearing, punishing, hostile, absent. Any of a number of issues can take place in childhood prior to age 7. By age 7, all bets are off. You're finished being programmed from that perspective. So if you lack the coping mechanism to deal with your discomfort, and you're then exposed to the drug, you're an addict. That's how you build it. It takes those three things. Now, the three things that I just gave you, one of them is pre-programmed, it's genetic, we can't fix it. The second one we could talk about through preventive measures in terms of parenting at a very young age. We could do something about that long term. But the third one is the key. You need to be in an environment like the United States that says drugs are great. And that's where we are right now. We're in the middle of a population that is sitting out there looking at adding a third legal psychoactive drug to the system, despite the disasters caused by the first two, because they think drugs are great. Right? Smoking is the leading cause of morbidity and mortality in our country. Alcohol is the third leading cause of morbidity and mortality in our country. And yet I keep on hearing over and over again how prohibition failed. No, it didn't. From a public health standpoint, prohibition on alcohol was the best thing this country ever saw. Morbidity and mortality dropped like rocks. People did not die of alcohol-related disease during prohibition. There were law enforcement issues. There were criminalization issues, same as there are right now for marijuana. The public health was in great shape. Then they said, no, we have to legalize alcohol because we all love it. And so they did. And now we're sitting here where alcohol is the third leading cause of death and sickness in the country. We wouldn't have ever had to deal with the ACA, remember the Affordable Care Act just a couple of years ago? We would not have had to deal with that if we had cut health care costs simply by saying, no more tobacco, no more alcohol. the entire issue would have been off the table because the healthcare costs would have dropped again. But no, we would never consider that because we want our drugs, right? And that's what's going on first with opiates in an insidious method that it sort of came from industry. Yeah, follow the money on that one to figure out why. And second, with marijuana, which is coming in equally insidiously through industry, through the public. But it's still a follow the money issue. Because big marijuana is going to be as big tobacco. And they know. So let's look at opiates for a second, because what happened there is pretty straightforward. Doctors about 15 years ago had been told, don't use opiates, they're dangerous, they can cause problems, just as you heard before. There are the acute issues where opiates are good. Then doctors were told not just that opiates could be used long term, but they were incentivized, right? They were told specifically that pain represented a vital sign and that they had to work to get the patient's pain level down. They were also told simultaneously that patient satisfaction measures would now be taken, and that the degree to which they received bonuses, the degree to which they were kept on as an employee, was going to be based on their satisfaction rating. So, imagine, if you will, a patient comes into the ER, he's drug seeking, he's requesting additional opiates for his chronic pain. And the doctor sees him and says, I see you have chronic pain, what would you like for that? I'd like some Vicodin, doc. Well, what will my patient satisfaction rating be if I do not give the Vicodin? It would be low. I would therefore give the Vicodin. That will keep my patient satisfaction rating high and will keep me employed. Simultaneously, I might check the prescription monitoring program to take a look and see what has been prescribed to this gentleman in the past. If I'm bright enough to do that and I know, okay, great, and, oh, wait, the methadone that this guy is getting from the methadone center, that's not in the prescription monitoring program. So all of a sudden, for docs like me who focus in this area, it's only partial information. All right, I can get around that. I can try and work with the local methadone facilities and try and get some information, but I can't because 42 CFR Part 2 makes that impossible. So I can't get the other information that I'd like. And oh, wait a second, the patient could have just gone to Rhode Island or New Hampshire to get a drug, and the state visit prescription monitoring programs don't talk to them. So it's not perfect. And even from the side of the doc who wants to do right by these folks, we can't because we only have part of the information we need. All right, so now we're in the middle of a situation that looks like this. That's a bar with the entire population. This is the group of people who are susceptible to addictive disease. And this is the group of people who were exposed to narcotics 15 years ago. Now what happens is a percentage of these individuals actually have addictive disease. Not everybody who's exposed to a narcotic has addictive disease. Only about 10 or 15% do. And you might say that percentage varies because the people likely to seek it out might have a slightly higher incidence. Not going to bother with that. As doctors were told, prescribe more of these drugs by various sources. They did so, but they did so without checking with each person to see, do they have addictive disease? Why not? Well, how do we do that? Let's say you come in and you've got addictive disease, but you've never been exposed to a narcotic. You have the first two building blocks. You don't have the third. How would the doctor possibly know that you have addictive disease and you're the one who's going to get hooked? Well, there are a few ways. They could start out by doing a drug screen and seeing if you're using some illicit psychoactive drug. They could ask you if you smoke. They could ask you whether you have a family history of addictive disease. They could even talk to you about your family and what it was like growing up. And each one of those things would give them a clue. But most pain docs haven't been taught to do that, and most docs prescribing narcotics haven't been taught to do that. And so when we talk to doctors and say, this is what you need to do, they say, well, we don't have time to do all that. We don't have the expertise to do all that. And there are so many people with chronic pain that we would just be flooded. There's no way of getting around it. And so it, in general, is not done. Now, experts one approach to that. There are a number of others that could be utilized, but there are more questions than answers in terms of exactly what these docs should be doing on folks who are narcotic naive, if that's the direction they choose to go in treating them. Because a percentage of them are going to have the problem. Okay, so more people are treated with narcotics. Suddenly this number starts to rise. And so what we see is that curve that we saw before that basically says, all right, now we've got a lot of people using narcotics. They have narcotic dependence, opioid dependence. And now what do we do with them? Well, we can send them to an opioid dependence treatment facility, but they're full. Now, here's the next odd thing that's happening. So buprenorphine facilities and clinics are full. We're at our 100-person cap. A person comes in to get the buprenorphine. We give them the lowest dose that they say they can tolerate. Now, we don't know for sure whether or not they're selling some of it on the street. There's no drug test in the world that I can use to see if they're taking the dose that I've asked them to take. There's nothing I can do to make sure they're taking that dose every day. Right? The pharmaceutical companies are working on additives, and there are additives that will allow that to be measured. That's a few years off at the very least. So that can't be done. So these folks coming in to get their buprenorphine, they're selling some of their drug on the street to make a few extra dollars. Why does the drug have any street value, though, given that it has a ceiling effect and that people really don't get high unless they very much abuse the product, which most people aren't doing? Well, it has a street value because the doctors are full, because there's a 100-person cap. So the doctors are prescribing enough, frankly, to get some on the street so that the patients who can't see the doctor because the doctors are full have the access to the drug that helps them from their opioid dependence. Well, the regulators and lawmakers, not quite in Massachusetts yet, Tennessee, Ohio, West Virginia, see that and say, oh my God, there's this other drug on the street that shouldn't be on the street. We'll have to regulate it by cutting back on the prescribing of the buprenorphine. It's the exact wrong direction. Right? What you want to do is make it so the doctors can prescribe as much as they want. Then it would have no street value. Right? But that's not the direction folks are going in because the drug's expensive. So the managed Medicaid programs sit there and say, this is now the #1 drug in terms of cost. Used to be opioid dependence was cheap for us. Now it's the most expensive disease in the world because it has a drug associated with it that's expensive, and the number of people with the disease is going up. And so they look at it and say, we've got to cut the expense. Well, if you cut the expense and the prescribing drops, then the number of people who are able to get properly treated will drop. They'll end up going back on the street to get their drug, and the drug will continue to have a street value. At the same time, pill mills are being shut. And because the pill mills are being shut, all of a sudden you've got a bunch of people out there who were prescribed Vicodin, hydrocodone, you name it, who now don't have a way of getting treated for opioid dependence because the bupe clinics are full. Don't have a pill mill from which to get prescribed narcotics. They get pushed to the street, and what do they get? Heroin. Because it's easily available and cheap. And so we expected, and at ASAM we said 3 years ago, shut the pill mills, don't change the cap, you will get a rise in heroin. We announced that in a press release 3 years ago. What did we see? A rise in heroin. No surprise, we all knew it was coming. Heroin's cheap, it's pure, it's available to be snorted. It was guaranteed that that was the only outcome possible unless you opened up some of the other valves. No one opened up the other valves. So now we've got heroin being used and more deaths. And again, entirely predictable. So, you know, as I sit here and say, we're doomed, it's because the things that make sense that would open up the system and let it work the way it's supposed to work aren't being done. And in part, they're not being done from a regulatory or lawmaking perspective. In part, they're not being done because the public simply isn't well educated enough on the topic. And so to switch over to marijuana, we've got the exact same thing. We've got a drug that has absolutely no benefit whatsoever. It doesn't do squat for a single medical illness out there. And yet, we've got a public out there saying, this is medical, it's medicinal, it will make you feel better. Well, sure, you go back 100 years ago, you could get those little bottles of, Dr. Phil's magic potion, right? And what did it contain? Largely they were narcotic. And it would make people feel better from whatever they had, right? Well, marijuana does the same thing, so does alcohol, so will a swift kick with a hammer on your head. They'll all take away pain to some extent. So most of what you're doing is making it so you can't remember what was going on at the time. Or it's making you stupid, or it's making you so you black out. And either way, you're going to go through and at the end of the day say, yeah, that felt better than yesterday. But it doesn't make you better. It's the same sort of thing as if I took somebody with tuberculosis and if I gave them methadone for their cough. They would feel much better. Methadone works beautifully for cough, probably the best drug out there for it. And yet, I've done nothing for their TB. Their morbidity and mortality is no better, not improved. So when you look at the medical data for marijuana, most of what we've seen over all of the studies that have been done, most of which have been small scale, not double blind, not placebo controlled, have at best a suggestion that there could be some improvement in one thing or another as a result of the marijuana use. Look at glaucoma, for instance. Intraocular pressure does indeed drop during the use of marijuana. If you actually wanted it to work for glaucoma, you would need to be stoned all day long, every day. That's the only way it would work for glaucoma. If you wanted to work for wasting disease in, say, end-stage HIV or some other cachectic illness, okay, yes, it gives you the munchies, you can gain a little bit of weight, no question. But there are other things that work better. And indeed, if it's end-stage, a terminal disease somebody has, I don't care what they do. They can smoke as much pot as they want. If they feel better, good, go with God. But in terms of 99% of the population, in Rhode Island, the average person receiving a medical card for marijuana use is a 30-year-old male with a history of substance use disorder. That doesn't make any sense. These people don't have chronic pain or wasting diseases. And now Rhode Island wants to add PTSD to the list. I can't think of a worse thing to add to an allowance for medical marijuana because we've got plenty of literature that shows that the big problem in many of the folks with PTSD is the concurrent substance use disorder. So we're sitting here with a public that's had the wool pulled over their eyes, that has the suspicion that there is not only no risk, but medical benefit to the use of a drug, which, one, is much stronger than the drug that was available in Vietnam. Two, causes psychosis in a significantly higher percent of people than you would otherwise expect to get it if they weren't using marijuana. And a drug that's been demonstrated to cause neurologic structural abnormalities that are probably responsible for the loss of IQ that takes place. And the loss of IQ appears, not certain yet, to be permanent. When is it permanent? It's permanent in the kids who use it. Kids being anyone under 25, because the brain doesn't stop developing until 25. So we're sitting here looking at a drug that has known negative outcomes that are significant, right? If I just, let's see, if I had one little factoid here that I think is interesting. Here we go. 7 studies have shown a 40% increased risk in psychosis in marijuana users compared to non-users. And if marijuana use starts before age 18, there's a 6-fold increase in schizophrenia later in life. Now, you could try and make an association. You could try and guess, well, the people who are going to get schizophrenia might have some abnormalities even before they get it. Maybe that's driving their marijuana use. And so maybe you're self-selected somehow. All right, I could buy that to a little extent. 6-fold? Do you think to a 6-fold extent the schizophrenics are self-selecting even prior to having any signs of the disease? I don't think so. I think marijuana is causing it. And the research seems to be more and more supportive of that outcome. So if we've got a 6-fold, let's even call it a 4-fold increase in psychosis. If you were 17 and you were told, you can try this drug, but it will make it 4 times more likely that you'll be psychotic, would you really want to do that? You probably wouldn't. Maybe you'd think it through a little bit. But if you're told, this is a medicine for a lot of people, and it has no bad qualities to it, and it's legal, by the way, you can buy it down the street. Would you use it? Well, of course you would. Right? Now, even better are the states that say, oh, we don't allow anybody under 21 to buy the drug. I think we have that rule on tobacco and alcohol. How many people have friends or patients that you've worked with who started using alcohol and tobacco only after it was legal? Anybody know anybody like that? No, because that's not the way it works. That's what high school bathrooms are for. So you sit there and say to yourself, why would we expect this to be different? It won't be different. It'll be the same thing. So, really what this boils down to is this question of in what direction do we want society to go in over the next few decades? Do we want society to be in a position where we've just accomplished so much with tobacco over the past 30 years, right? I was in medical school in the late 80s, and patients were smoking in their hospital beds. They would take their oxygen mask off, and they would smoke. The president of the board of the hospital, Mount Sinai, would smoke during board meetings. There were ashtrays in the back of the seats in the medical school, right? I mean, this was routine in the 80s. You could smoke on airplanes and trains, in office buildings, anywhere you wanted, grocery stores, you name it. It was all there. And now, that would be absurd. If somebody walked into a Stop and Shop and lit a cigarette, and that's not going to happen. But just a few years ago, that was normal. So we've made huge gains. Why do we want to take a step back? Why would we possibly want to impose that unless the public really believes that this particular carcinogen, this particular drug that causes stupidity, really, is something that should be used? Right? That was the one point I didn't make here, that 8 or so point drop in IQ. I had an argument, I went to MIT for undergrad, and I had an argument with some of my marijuana-using friends there who say that they've never noticed a problem with their marijuana use. And I said, well, you started out with an IQ that was, up a little bit, and you came down 8 points. So let's say you started at 130 and now you're at 120. Yeah, I don't think you're going to notice a whole lot. But if you look at the socioeconomic spread of people who tend to use drugs, they start out at a below average point for the most part. So if you're starting out, let's just say it's 90, right? 90 IQ, all right, you can do most things. You can get out there and get a job and be productive. But now you're lowered to 82 on average, right? How competitive is an 82 likely to be in the U.S. in terms of getting a job? How productive will they be? And that's what the state legislatures have to focus on. Because all they do is focus on money. All right, good, let's focus on the money. You'll bring in tax revenue by legalizing and regulating marijuana. But you'll end up with a less productive population with higher morbidity. Not within the 2-year election cycle, unfortunately, but longer term, right? These people are going to end up costing you money. And we can look at tobacco and alcohol for that. 10-to-1 ratios, right? For every dollar brought in to government by taxation, the government spends 10 from different silos, admittedly, on health consequences and productivity losses and disability, right? Why are we adding another drug? Didn't we want to keep costs low? This would not be a good idea. So, I have plenty more I could say, but I know I'm out of time, and I know that there's a question and answer section, so I want to leave that open. So thank you all for listening to me.
Thank you very much.
Thank you.
So there is a question and answer, but before we even begin that, in the very beginning of our agenda, we said that we were going to give certificates of award. I'm just going to give them to you afterwards. I'll just mention who we're going to give it to so we can get to the questions. Is that fair with everybody? And we have many people in the house, too, that I want to honor coming today. this Friday, holiday weekend, Cape Cod, almost summer. Yay, almost summer. So thank you all for making the trip here. So the certificate of appreciations go to DeWitt Davenport from the Davenport, you know his recent contribution to our community, and Joel Pearl as well. Don Matson from the Tower Foundation, who has been very supportive of the Freedom from Addiction Network as well as the Prevention Partnership. And then we have Jeannie Yarrow. Speaking of which, Jeannie is the adjunct professor at the college of a group called START, and they're doing amazing prevention work on Cape Cod Community College. So please, Jeannie's here, raise your hand. Jeannie is also on our board and has been an amazing partner in putting this together today. We have Danielle Boland from the Massachusetts chapter of, she's the leader of Young People in Recovery, and wave your hand too. Possible without James McKenna from AdCare, big contribution from AdCare Hospital, and Ray Tomasi from Gosnell of Cape Cod. Amazing support from Dan Wolf's office and Sheila, Sue Rohrbach is here today in the crowd as well. Thank you so much, Dan. And nothing in Cape Cod would get done in this area without Mary Ann Frank-Willis of Moore. She's here and among us. Michael Jackman, so we'll have him come up. And Nicholas, of course, for the film. Randy Hunt, who is our speakers, Stuart and Bertha, and Will Woozy. So we did have one last speaker. Michael, you'll come up very quickly.
Yeah, I'm going to be really quick. The honor of being the final person before the Q&A. Thank you, Kate, and thank you to everyone for being here today. It's really an important topic. I do have a few family issues. I have family members who have been affected by this, 2 nephews who are both opiate addicted, and that still struggle with it today. They're both in their 20s. So it's a very personal issue for me. I worked for Congressman Bill Keating, and when he was a DA, prior to his being elected to Congress, I worked as his director of school programs. I worked with a lot of different community groups on substance prevention. And one of the things we always learn, which a lot of the groups down in the Cape know too, is you have to work in multiple strategies in multiple settings. So it's been said before today, but I think it's important that we remind ourselves that there's no one solution to the substance use problem, but every person in this room and every person in the community is part of the solution. So we all have to be working to make sure that we're combining our efforts towards the same goal of making our communities as safe as possible. A couple things I just want to talk about real quickly is some of the federal efforts that are going on, especially around prescription drugs. The FDA back in September changed some of their rules regarding some of the opiate painkillers, new labeling procedures that will hopefully because there was some ambiguity about what was severe pain, what was moderate pain, and what doctors should go by when they're prescribing these drugs. And the new labeling is that these medications are indicated for the management of pain severe enough to require daily, around-the-clock, long-term opioid treatment, and for which alternative treatment options are inadequate. So that clarifies for the docs what they should be looking for when they're prescribing these drugs. It's all these efforts are about making sure that the people who really need the drugs get them, not people who don't need them. And you know, we heard today, those are the people who are more likely to be abusing them. Unfortunately, there's also there's no across-the-board policy on the abuse deterrent technology. Dr. Madra talked about tamper resistance. One of the bills that Congress was the main sponsor of is the STOP Act, which would incentivize drug companies to market these opiate painkillers with abuse deterrent formulations. The FDA did make some decisions towards this goal, but the act itself would require that of all opiate painkillers. including generics and brand name. So those are some of the efforts on the federal level in Congress. We already talked about, Will talked about the DEA drug take backs, which are great avenues for communities to come together and take a stand and make sure there's awareness for folks who have old prescriptions in their medicine cabinets, that they have the opportunity to get them out of the medicine cabinets, get them off the streets, get them away from the possibility of being abused. And I would urge everyone, as Will said, go to DEA.gov and check out. There's plenty of sites around the Cape and all throughout Massachusetts. And they're great events just to raise awareness too, because I think a lot of people, they don't know how to get rid of the drugs. They just assume that they should hang on to them, you know. But this is a great opportunity to raise awareness about that. The last thing I just want to talk about real quickly is the drug-free communities grant funding, which some communities on the Cape do have. The communities I work with in the DA's office, a lot of those coalitions were funded through the drug-free communities grant, which is part of the Substance Abuse and Mental Health Service Administration at the federal level. And those are great opportunities for communities, again, to come together, parents, youth, educators, law enforcement, academics, medical professionals, coming together to talk about the issues on the community level. Because as I said, we're all part of the solution. Every person here, every person in the community has some part to play. And it's through, I think, again, it's through collaboration, it's through coalition that we can change policy, as we're trying to do on the federal level, change practices in our community, change attitudes, and we can change behaviors so that young people and the entire community are moving away from the decisions we use these other programs. So very quickly, that was my presentation, and thank you, and thanks, Kate.
So we do have a very little time for Q&A, but we may go over if it's okay. But in front of you, there is a form to fill out that we'd love you to take. There's an evaluation form for the event, and we'd love you to take some time to do that while we are posting some questions. Are there questions of any of our speakers? Yes, up in
To Dr. Madras, outside of the psychiatric discipline, what does the average physician see in alcoholism or addiction training?
My office, when I was working at ONDCP, commissioned a study to try to understand what the knowledge base was for addictions. And it's very, very limited. Almost all medical schools, there are about 125 medical schools in the country, they all teach how to recognize alcoholism through the CAGE questionnaire, which is a 4-question. And that's pretty much it. The intake forms that physicians use when they have new patients or annual visits will ask about smoking and alcohol. Some will ask about drugs, but most of the curricula do not tell physicians what to do next. In other words, if somebody says, yes, I use marijuana, yes, I use opiates, there is no real training on how to follow through. So there is approximately somewhere between 35% of medical schools do have a core curriculum in addiction. The majority don't. But what is equally, from my perspective, a massive shortcoming is to recognize people who are not only addicted, but people who are on the path towards, who are at risk, who are engaged in problematic use. And this is what this ESPER program wants to address, is to get people at very early stages. And that is simply not even part of the curriculum. It's now mandated through the Affordable Care Act that ESPR has to be implemented for a certain population of care that's federally funded. But overall, there is very, very weak attention to addictions and to problematic use in medical school. It's a minority in medical schools.
Thank you, Doctor. Go ahead.
Yeah, along with that, I was alarmed when Massachusetts passed our Prescription Monitoring Act. The Mass Medical Society didn't want to add on the educational piece to it. I was on a behavioral health task force to make recommendations for overall payment reform. We wanted to make a recommendation that there be more schooling in for doctors for healthcare. The doctors on the committee fought it because they said they have enough. What can happen to turn that resistance around?
The licensing board. The Mass Board of Registration in Medicine can make it mandatory that part of good medical practice is that you have to look at the prescription drug monitoring database for your patients and for the pharmacy. You can nail it through the licensing.
Could we influence the licensing?
Oh, yes, you can.
Okay.
And another question,
Is there anything being, I don't know who the answer is.
a
but-
broad question.
Yeah, is there anything being done to prevent pharmaceutical companies from pushing out these increasingly strong opiate drugs? Anything?
Well, the Zohydro specifically, the governor,
I know you tried.
right, and there is a bill actually in Congress to ban it as well.
It's just unbelievable. I mean, I know it's fueled by money,
Yeah.
but still, it's unconscionable, really.
I'm just wondering about how the scientific panel voted against it 11-2, and yet the FDA approved it. Is it going to, obviously they can do it. I'm kind of wondering if like the FDA should be, if they should investigate that though, because it doesn't make any sense to me.
Part of it is that
Zohydro can be tamper resistant. It's just that the pharmaceutical companies choose not to because it costs more than to make the other. I'm sorry, go ahead.
Yeah, no, part of it is that the FDA could make a decision that ran counter to decisions they had made for other companies' products unless there had been a change in the regulation that had taken place. The change in tone coming from the Scientific Advisory Board was based upon what's going on with opioid dependence. And what would end up happening is that the FDA would say no to a latecomer to a field where they had already said yes on comparable drugs. So that was one issue. The second issue is that Alquist has the product now. They actually bought the company or absorbed the company that made Zohydro. And what they said, I spoke with David Gasparent, who just left there as their medical director. And he basically said, look, the drug was developed initially without tamper resistance because it was a faster approval curve. The tamper resistance process takes a little bit more time to get in place and to then test and be sure it works. And so that's coming. It's actually the next product that they have on the drawing board. But they wanted to get drug number one out there so that they would have some commercial viability and some sales and some revenues to help drive the process of working on the rest of it. So it's a money issue. But it's not simply that they were saying, let's put the evil product out first and then we'll move on to the next one. I don't think that's the thought process.
I'm wondering if you'd be willing to say a few words about what you're seeing, District Attorney, in the community. Are you open to perhaps saying a few words?
So much has been said so well today. I'm glad that I was able to get here to hear most of it.
You might want to introduce yourself. I think you do a great job. The rest of the people who
I'm
might not-
Michael O'Keefe, I'm the District Attorney for the Cape Cod Islands, and interestingly, Dr. Mathis and I worked very closely together in 2008 on ballot question 2, and traveled all over the place in a losing battle, incidentally. But and as Randy observed a few moments ago, you know, in 2016, when I fully expect the complete legalization to be on the ballot in Massachusetts, and I was, as Randy articulated a while ago, you know, very pessimistic about that, and that would pass easily. I'm a little less pessimistic about that when I see that, again, the Globe has, you know, published a number of stories recently, including the one the other day about the research that I'm sure was referenced here at some point today, that tells us that even the casual use of this drug that everyone thinks is so wonderful is very deleterious to the development of the kid's brain. And why we want to put yet another intoxicant in front of kids with the imprimatur of the adult community that, you know, it's really okay, is just beyond me. But I think as we are marching forward in this country, the Oregons and Colorados and Washingtons and now Massachusetts, the Netherlands, you know, which has had this for quite a while, they're starting to walk it back because they know what it's produced. And, you know, I think that's not lost on people. So let's not give up hope that the tide can be turned on this issue in 2016. We have, you know, 2+ years to continue to educate people about, you know, the dangers of this drug. And let me tell you, from my perspective, having been a prosecutor for 30+ years, while it's certainly true that not every person who smokes marijuana is going to turn into a heroin addict, every single person who's a heroin addict started smoking marijuana. And go someday to see Sheriff Cummings at the Barnstable House of Correction, that beautiful facility on the Air Force Base. It is loaded with people who are there because either they were abusing a substance when they committed a non-drug crime, or they're there for a drug crime. It's as simple as that. And unless we begin to recognize that this is, you know, a kind of a pernicious influence on our young people. And, you know, when we used to go around, I used to say, I don't care if some 30-year-old engineer who lives in Wellesley and makes, you know, 300 grand a year because he's a smart, successful guy, goes home at night and smokes a joint. I could care less about that. What I'm concerned about is the idea of the adult community saying to kids, this is okay. At the same time that I can't have a cigarette anywhere in the world today without somebody jumping down my throat. And so, you know, think about that for a minute. Think about your young kids, your nieces, my nieces, they look at me like I'm from Mars if they catch me with a cigarette. We have not made that effort with drugs and young people. And we should be about the business of doing it. And I'll leave you with one last thing. And I got a great explanation for what I anecdotally and have heard for years from the doc today. The exact same percentage of people that were addicted to drugs before the DEA was created and our war on drugs was created is addicted to drugs today. What does that tell you? It's proof of what the doc was saying. But we can impact, you know, that behavior, particularly in young kids. And that's what we ought to be doing. And I have 18 state troopers assigned to my office. 9 of them do drugs, and 9 of them do bodies, because under the law in Massachusetts, I'm responsible for the investigation of every unattended death in my jurisdiction. The sad thing is when those 2 units are working on the same case, as happened in Bourne the other night, when, you know, a heroin dealer goes bad and they shoot, stab, and kill the guy that they're going to buy the heroin from. And so when you hear this message sometimes coming from politicians that, we've got these poor, low-level drug people languishing in prison, and we should let them out. You have to earn your way into prison in Massachusetts. And there aren't any low-level drug dealers in prison in Massachusetts. The people that are in prison in Massachusetts are the people that are selling and pushing drugs on kids to expand their base and, resist that notion. And to leave it on a happy note, be positive, influence as many people as you can. Just call their attention to these articles that are going to appear with an ever-increasing frequency, I think. Glad you're all here. It was great to listen. Good to see you again.
Something to keep in mind on that is that 20% of substance users are responsible for 80% of the substance use. Now that's something to keep in mind because that's what keeps the alcohol companies in business, right? And the other thing to keep in mind is that those people who use heavily, in other words, the 20% who are using 80% of the product, have to start early. Because the earlier you start, the more you'll eventually use. People who start smoking, for instance, at age 25, never go to a pack a day. They usually stop somewhere around 3 or 4 cigarettes a day. So the earlier you start, the more you'll smoke. The earlier you start drinking, the more you'll use. So it's in the company's best interest that we start to see marijuana sales begin to get promoted, to get kids using, because the heavy users are the ones that will be responsible for keeping the companies afloat. That's why in Colorado right now we're seeing products like Hot Tarts, right, and other sort of candy and cookie-like products that are being promoted so that the kids are attracted, whether or not they're acknowledging that they're pushing that market.
I'd love to just add one thing. First of all, District Attorney Michael Keefe is one of my heroes. We went to the Boston Globe for Proposition 2, which was to decriminalize. And we reversed their editorial stand, and they created an editorial that said, don't vote to decriminalize. I was at the Boston Globe again in 2012 in the editorial office with a different team on the marijuana as medicine proposition. I think 8. But here is how well organized, I'm reiterating what Dr. Woodrow said. Here's how well organized the marijuana lobby is. Do not think this is a grassroots movement. I went into Wikipedia because they stated that all the newspapers in Massachusetts supported marijuana as medicine. And of course, they didn't list the Boston Globe. I went into the Boston Globe archives, got the exact language, cut and pasted into Wikipedia, and as I did, it was edited out. And I tried it 4 times, and it was edited out on real time. So there are people monitoring these public encyclopedias to prevent the public from learning of the opposition.
Which is why fans here. It creates awareness and education. First of all, thank you to everyone that came and spoke. I don't want to go through it because we'll just be here more time. But there are lunch bags outside which have the Freedom from Addiction Network logo on it, but also there are lunch bags and there are some sandwiches. So if you'd like to take a sandwich and a lunch bag, that's the one thing. And I'm going to close, as you know, I'm a yoga therapist and health educator, so I'm going to close with this and we'll just take a moment. Don't worry if the work is hard and your rewards are few. Remember, the mighty oak was once a nut like you. It is wonderful to get up in the morning knowing you are doing all that you can do. The important thing is to keep your intention clear. And finally, words from Jeanette, I think it's Osius, but I'm not sure. Right now, my life is just one learning experience after another. By the end of this week, I should be a genius.